My name is Mac Gladden. I'm a behavioral scientist in the Division of Overdose Prevention at CDC. Next slide, please. Oh, sorry, that's me. There we go. A little housekeeping. For this webinar, the chat will be disabled, but if you have questions, please feel free to put them in the Q&A, which is located on the top of the Teams bar. Also, I just wanted to say the findings and conclusions in this webinar are those of the authors and do not necessarily reflect those of CDC. So in this webinar, we really have three major goals. One is, why did we build this dashboard? What was the key function? How would we like you to use it? And what are some of the pitfalls to avoid? Then we'll go through the three major web pages on the dashboard, the actual dashboard, its accessibility page, and a key findings page, which just provides simple key findings up front. And then we'll end by talking about future directions. So we're going to start with, why did we build this dashboard? What purpose does it serve? What gap does it address? So looking at recent CDC data on drug overdose deaths in 2024, about 96% of fatal overdose deaths involve an opioid, a stimulant, or both. Indeed, among these 43 jurisdictions in CDC's system, 43% of drug overdose deaths involve both an opioid and a stimulant. If we go down and see, okay, what are the specific stimulants and opiates involved, we see 65% of deaths involved in illegally made fentanyls, and most of that is just illegally made fentanyl. And stimulants now, over 60% of deaths have a stimulant contribute, and the vast majority of those are either cocaine or methamphetamines. What this means is, when we're looking at the drug overdose epidemic, we really need to quickly identify changes in these drugs and their co-use, incidence, or how much people are using or being exposed to. So there's been great strides in providing more timely drug overdose data. There's 12-month provisional estimates that are published, but they're meant to smooth out rapid changes. So we also need systems that pick up those rapid changes. And also, when we see a change in drug overdose, we want to try to test our ideas on why it might be going up or down. So that led us to look at the ability of clinical urine drug tests to act as an early warning, early insight into drug overdose trends, and also what's going on in the drug overdose epidemic. Specifically, the data on the dashboard comes from Millennium Health, an accredited laboratory that provides drug testing services that helps clinicians provide care to patients by monitoring prescription drug use, illegal drug use, and the effectiveness of their treatment plan. It has very in-depth testing, and the data is very timely, available usually within less than 2 weeks of the test. So for the dashboard, focusing on these drugs I just said, illegally made fentanyl, cocaine, methamphetamine, we focused on adult patients with a substance use disorder, excluding alcohol, cannabis, and tobacco. And we really focused on positivity. How often was fentanyl, heroin, methamphetamine, and cocaine detected in this group? And the advantage of this data is there's a lot of tests, over 650,000 between October 2023 and December 2025. So, as I said, the data is extremely timely, and we're working to update the data 1 or 2 months after the end of the quarter. We probably released Q1 and Q2 together. There were some unexpected hiccups. But the other real strengths of the data is it provides clinical insight into people with substance use disorder and treatment. And that is a group at high risk for overdose. And more broadly, accumulating evidence shows it can provide sentinel surveillance of major changes in the drug overdose trends. And also it provides insights into co-detections of substances. And that's important because that can complicate treatment and recovery. Here I show you two trend lines. The line in orange is the trend in overdose deaths. With that line in blue is kind of model estimates using Millennium Health data on fentanyl positivity, methamphetamine positivity within fentanyl, and then concentration of both of those positive drugs. And what you can see is it predicts pretty well the line, but most importantly, it moves up and down when there are major shifts. So this provides evidence we may be able to use this as an early warning system. But when we move and use this data, we do have to note its limitations. It's a sentinel system, which means it's not nationally representative. You can't compare fentanyl positivity in the West and the East because different clinical practices may be involved. You may have patients with more severe opioid disorder in one region than another. And it only describes a small portion of people using drugs. And while it's an important population receiving treatment, it doesn't get as broad a view of some of the recreational drug use. And this is just data from one of multiple companies that provide the service. The last limitation we should always keep in mind, this is detection. So I can't distinguish between intentional, the person want to take the drug, versus unintentional exposure. And also detection doesn't mean they used it at the same time. It detects exposure over, depending on the drug days. So it could be used sequentially. It could be used at the same time. We don't know. So kind of this key takeaway is we are hoping that the data helps us more rapidly pick up on new trends and test kind of ideas of what might be driving them. It also lets us look at co-detection among people receiving treatment. And also because there's enough tests, we can look at the different regional trends. A big lesson is different regions in the US can face very different problems because the drug markets are different. And just reiterating the cautions, convenient sample, really people with substance use disorder, urine that are being tested, receiving treatment from one company. It's really focused on trend changes more than absolute values. And like any sentinel system, we should use other data to confirm its results. So we provide all this information on the dashboard. When you first open up the dashboard, there's an About Dashboard section we encourage you to read. And then underneath the dashboard data, there's an important data considerations. So now I'm going to move from kind of why to actually a quick review of the dashboard, and then we'll end with some key findings, future directions. When you look at the dashboard, we purposely decide to focus on key drugs that I discussed that were really involved in a lot of fatal drug overdoses. The other advantage of focusing on these drugs is they're routinely tested by Millennium Health. So we maximize the number of drugs. And we want to put this system out and then learn from it and expand based on that experience. We focus on 2-year time intervals because it really is meant to be an early warning system. And the other thing we heard is some people don't have a lot of time. And when you hit the dashboard, you might just want a quick summary of results. We provide that. You might also want a little bit more in-depth information. So we try to provide that with tools. There's 3 specific websites. The main one you should go to is the dashboard page on the left. We also have a key findings page and an accessibility page. I will go and now describe each one of these. So let's focus on the dashboard page. One of the unique aspects of this dashboard page is right above the dashboard, you'll see the key findings for fentanyl. Fentanyl has been a major driver in the drug overdose epidemic. So we wanted to provide key findings up front if you want to look at them. Findings for other drugs, however, have to be seen on the key findings page. And you can access key findings either through that key findings section or at the bottom of the page through related resources. When you go to the key findings page and open it up, you'll see a blue box that provides the general result and then a very short sentence about maybe some of its implications. So let's move to the actual dashboard. We'll return to the key findings a little bit later and more in depth. So the dashboard has 3 key parts shown on this slide. The top part lets you filter by geographic region, drug, and time frame. The tables underneath, one provides you kind of general trends in how often that drug's detected in this population. And then the third part in second table, it lets you focus in on drugs detected within fentanyl, within cocaine, within methamphetamine. So let's take a look at the filters. So first you can select a region, and we give you the option of overall any sample collected in any specimen collected in the United States, and then the 4 census regions. And personally, I don't know all the states in the census regions offhand. So when you select a census region, we provide a map so you can quickly see what states are included in that region. Moving to the selected drug, just four drugs: fentanyl, heroin, cocaine, and meth. As I said earlier, fentanyl, cocaine, and methamphetamine are major drivers, and heroin historically was a driver, and so we keep it on the dashboard in case there's a resurgence. And we also provide a time frame. Most people, I think, will be interested in the quarterly time frame, and we avoided monthly to kind of smooth the trends. But 6 months, you might want to see how long a trend's going, get a little bit more power in the analysis. And for the Northeast specifically, we don't have as many specimens, so you might want to use the 6 month when looking at that data. So I've already described right under the filters, there's a little summary so you know what you filtered to. The geographic. We also, in the second box, show, okay, how many specimens are in there, and then the time frame. And finally, because this is a convenient sample, we want to just remind people all the time of some of its limitations. And so the third box really focuses on that and provides advice. So if we move to that first table, we made the table have 3 major sections. The title, which provides key information, and you can double check to make sure you have the filter you want. Some ability to select lines to clean it up or focus on results of interest. And then we can turn labels on and off depending on detail. And also we provide automatic calculations of some changes. Let's take a look. Starting with the title, every title will list the drug, the region, and the date. And that's so you can always confirm that filter is getting what you want. Then say, moving down to selecting a line, say we were interested in fentanyl without cocaine or methamphetamine. That bottom blue line, it's kind of hard to see on this scale. And we might want to have the labels pop up so we can better see if this looks really close or not. So we just click that line, and what's nice is the dashboard will zoom in so you get a better look at the trend. And now you can look at the labels so you can evaluate kind of the absolute magnitude of change and what's been going on over the last 2 years. Finally, what's this percent change off and how do I use it? If you leave it off, you can roll over the point and it'll just give you the percentage, and it'll also give you a 95% confidence interval, which gives you a really nice feeling of how precise this estimate it is and whether we're seeing noise or a real trend. Then if you put change on, what it'll show you is yearly and quarterly change. And the arrow just shows general direction. It shows the relative change for the top line, 14.5%, but it also gives the percentages in that yearly change and in the quarterly change. So you can see, is it a big change, or a tiny one from like 1% to 1.5 versus 15%, from 10% to 15%. And I should say, we don't show data that's not on the dashboard. So for the earliest points, it'll just show quarterly change. So just in summary, this first chart just gives you a general trend in positivity, which other research has shown has predicted some major changes. And as a reminder, different factors could change this trend. So it's always important to confirm these findings with other data sources. The second chart is identically formatted the same way as the first chart. Same functions, everything's the same, except now instead of the denominator being all specimens tested for those 4 drugs, it's just one drug. So how often do you detect cocaine and methamphetamine in fentanyl positive samples? And the same caveats for this, interpreting this figure as the previous one. So now we're going to just touch real briefly on the accessibility page. The accessibility page is structured exactly like the dashboard. It has less descriptive information. So for limitation strengths, go to the dashboard page. The key difference is it provides the data in a table format, which is much more accessible and readable to a much broader audience. So we just wanted to make sure you knew that that function was available. So now I'm going to move to one of the things that we tried to do new, summarize kind of the key findings for you. You might not want to use the dashboard or just get a feeling of some key findings you might want to play around with on the dashboard. So let's look at the key findings page. So as I mentioned earlier, from the dashboard, you can get to the key findings page by opening up that fentanyl box, going to the bottom, or going to the bottom of the dashboard. And every key finding has a blue box, and that just gives a quick headline and the data. And then there's a short, usually 1 sentence, max 2, to describe some of the implications. So let's actually look at some of the findings. With fentanyl, it becomes really clear the importance of looking regionally. We saw significant declines in the Midwest and South from October, December 2024 to October, December 2025. And that is consistent with the argument that there may be less people using and being exposed to fentanyl, which is good. But in the West, we see a slight increase and a much more flatter trend. And this may be related to fentanyl being introduced later in the West, differences in the type of fentanyl market. There's a lot more pills when it was introduced, but it shows we can't just lump all the regions together. Let's take a closer look. So if we look at the Midwest census region here, you really see a very steady and large drop over 2 years, with the one exception of that January-March 2026. And I put arrows on the 1-year change, which is, very promising and consistent again with decreased fentanyl detection and exposure. The southern region, very consistent, steady drop over 2 years in fentanyl. But then we move to the western region, and you see relatively flat with a slight uptick in October 2025 to 2025 to 2026, October, December. And I should say we focus on the year to take out seasonal effects, but we also provide that quarterly data. And the advantage of that is with the western region, while we see this yearly increase, it does appear to be flattening out, and we might even see decreases. We anxiously await to post the 2026 data. Ugh. So moving now from fentanyl to cocaine and methamphetamine. I'm not going to highlight all the findings. I just wanted to highlight that in the southern region, we saw a pattern that we wanted to highlight, and that is both cocaine and methamphetamine without fentanyl and heroin were increasing from October, December 2024 to October, December 2025. And if we take a look, let's look at methamphetamines in the southern region. You can see that increase from 8.1% to 10.0%. And it's on the second line because that's methamphetamine without heroin and fentanyl. And it seems the primary driver of a general increase. You do see that this increase started around in that April-June quarter of 2025. When we shift now over to cocaine, we see a pretty steady increase over the last 2 years in that cocaine without heroin and fentanyl group. And it started all the way back in April to June 2024. So I hope this has been helpful both to kind of highlight how this can be used to look at trends by different regions. We encourage you to actually review the findings and dashboard to get the full group. And it's a reminder that it really is focusing on people with substance use disorder in treatment. And we are trying to get it available faster to give us an early picture of what might be coming. And then the changes we saw is we saw drops in fentanyl detection in the Midwest and South over the last year and really 2 years. But we did see the West increasing slightly, but hopefully stabilizing. And also we saw kind of this pattern in the South maybe of people using stimulants, illegal stimulants without fentanyl. And there's a concern that as fentanyl use drops, as if treatments with medication for opioid use disorder aren't available for stimulants, you don't have medications, but you do have contingency management and other behavioral therapies that are effective. We're worried there might be a shift in that group or people aren't as successful. So I'll end with possible future directions, and then I'll open up for your questions to see how we can help. So when considering future directions, we really want to see what problems and factors are we worried about or that might drive or change drug overdose trends. So first is the box of just overall exposure to kind of any of these 4 drugs. The second would be rapid changes in exposure due to how people are using drugs, if they're changing methods or how often they use it, or changes in drug purity. And a lot of concern over the last year or two are kind of drugs that are mixed in with fentanyl specifically, and a lot of the adverse health effects they can cause. Because if we can't treat withdrawal or wounds of a patient, it might be much more difficult to maintain their recovery and get them into treatment. And finally, we're always looking for or concerned about opiates that are even more potent than fentanyl, as it's tended to happen when we see a shift in the supply to more potent opiates. We also, unfortunately, see increases in fatal overdose deaths. Then there might be functions that are helpful. Looking at the patient, maybe providing a year aggregation to get a larger picture. So just a reminder, the chat is disabled, but you can put questions in the Q&A box if you have any questions for me. And I know I don't have questions. They don't come to me 30, 40 minutes, or there's a problem with the dashboard. You can always send those inquiries to this email at dopinquiries@cdc.gov. So again, I really appreciate your time, and I hope you find the dashboard useful, and we will be working to get new data up on 2026 and by the fall. Thank you. I'm going to read the question and address them. I'm just now opening that up. Thank you for doing that. Will additional private labs be added to increase national coverage? In the future, could the data be filtered by state and even county level? Those 2 questions are related and good questions. One of the reasons we haven't done state and county filters right now is because it's a convenient sample. There's really good coverage in some states, not good coverage in other states. So we were struggling with how to show that data. So that's something we'll discuss, which is linked to the second point. If we could stack data from other private labs and combine them all together, that would increase the system. It's something we're exploring, but require more resources. So I can't make any promises, but it's a great point and would make the system a lot stronger. Next question. Are there any efforts to build partnerships beyond to create yet? Right now, there is not. We wanted to release what we had. And also there's complexities. The private companies have to agree with public data sharing and providing their information on a timely basis. But I appreciate those comments. Why there's so few samples in the Northeast census region? It's just the market that Millennium Health serves. You know, they have different clients. And again, that's where other complementary sources would go on. But it's also why we thought it was really important to provide a 6-month view and to provide those 95% confidence intervals so you can know what you're dealing with, because the Northwest can look bouncy due to that reason. Is there a place to understand how many tests were assessed per census region? Right under the filter, we included all tests that had fentanyl, heroin, methamphetamines, cocaine. And for that, so if you pick fentanyl positive in the South, it'll show you what the denominator is in that second box for that time frame. We don't break it down by this data is just refreshing my post here. The HIPAA, this data is all de-identified. So this is all the tests. That one. We provide a link to the dashboard at the bottom. And from that link, you can find the accessibility page. You can also find the key findings page. And I really appreciate these questions. You're hitting. Since there is an FDA-approved medication for stimulant use disorder, is treatment defined, for example, as those who are receiving medication for opioid use, disorder happen to use stimulants, or does it include other health services? This dashboard, we really only focus on the urine test results. We don't have information, like patient-level information on the treatment they're receiving. And I think the CDC website can answer some of the questions on definitions and available treatments for both stimulant use disorder that are evidence-based and opioid use disorder. Trying to see if there's any other. With some states seeing an increase in orphans, do you all plan to expand testing to include new drugs and populate in drug seizure data or state-level toxicology data? Great point. I think there's 2 points here. One is, as we said in future directions, we are looking at carfentanil and reporting it, but we have to report it differently because it's almost like number of samples is the thing. And I think with orphans, it's so early, we need to see whether it makes it into commercial testing, but the lab does do comprehensive tests, and it's a good idea. And I also think that your point on data integration is really well taken. Like it's hard to go to all the data dashboards. How can CDC pull this information together in a good nugget across so you can do this comparison easily instead of having to visit each dashboard? Oh, this data, I may have missed this part, but they're just asking where the data come from. This data comes from Millennium Health, which is an accredited laboratory that serves people with substance use disorder. And so it focuses on patients in treatment, and the urine tests are part of the care that they're receiving. So it's from one company that conducts these, but they conduct a lot of tests. So that's helpful. So it's not related to EMS and biospatial, but CDC does do projects and does collaborate with biospatial. So it's a really good resource to detect trends, outbreaks, et cetera. We added the web address at the bottom. I'm trying to see if there's any additional questions. And again, if you have questions that come up later or as you're using it, please send that to dopinquiries@cdc.gov. I'll give everybody a minute more. I really appreciate your time. I know everyone's busy. If I didn't answer your question, please feel free to put in a follow-up in the Q&A. Daniel, I just wanted to check, did I miss anything?
There was one comment asking if there's any way to access state data.
Yeah, unfortunately now we haven't displayed state data, and that's because it's a convenient sample. And so we have some states the estimates are very precise. Other states it's not. So on this first launch, we wanted to do region so people can see what's going around, but it's an excellent question and it's something we need to grapple with. Okay, I'll stay on for another minute or two. If any more questions up. I think the first phase is to really focus on these quarterly trends. We will expand, but I should say CDC has other systems that, such as we're doing biosurveillance, testing of non-fatal samples in hospitals, and we're also doing really comprehensive testing of drug products and paraphernalia that we hope to get some of these emerging samples or tests early. And that information we hope to release next year, and we'll keep you in the loop. Thank you. What software is used to create the visualizations? Daniel, you want to talk about the software used to create the visualizations?
I don't know that I can really speak to that other than this built-in CDC template wide with our developers. They custom made a lot of what we see on the dashboard.
Okay. Yeah, and that's one you can send the inquiry. The landscape changes so quickly. I'd hope to see quicker data from CDC in the future. I appreciate that comment, and we're really hoping to get the updates faster. This is a question about cyclorophene. And please send that one to the DOP inquiry. We can direct you to drug product and paraphernalia testing that's been detecting it. And I think with cyclorophene, like with nitazines and with carfentanil, it's really important for the testing to look at the testing in your region. In some places it's not there, some places it's very rare, and then there's a few places that it has been detected. So I think it's a real value for more rapid surveillance. This isn't going to serve that purpose because commercial urine drug only starts testing when it becomes a kind of major factor and it gets ordered by clinicians. But yeah, definitely send that to the DOP inquiries. We can send you resources and more information. Corey Hilton, thanks. Other questions? Methamphetamine, that's great. And I would put xylazine there too. And that is one of the future directions that I think urine drug testing can help with. It is it's nested kind of within fentanyl and really looking at drugs co-detected with fentanyl and from other sources like drug product testing, we know it's mixed in together. Methamphetamine, Millennium Health has started testing for, and we are evaluating providing that data more real time. And I think urine drug test, well, drug product testing, really comprehensive testing, and the EDs might be good for the rare and emerging substance. I think urine drug testing really helps as a substance begins to be, a lot of people begin to be exposed to it. So we should get on methamphetamine. I really appreciate that comment. And I also, CDC just released a health alert advisory on methamphetamine not long ago, but integrating into our surveillance systems is critical. And that is something hopefully we'll be able to speak to more in the near future. I'll give everybody just a minute or two more to ask questions. Well, the last thing I just want to say, the webinar is recorded, will be posted, and please feel free to reach out PIA inquiries with any future questions, and the recording will be on the dashboard website page. Thank you for your time today.